Well, welcome everybody, and thank you for giving up part of your evening to attend tonight's webinar on the individual contracts for new to practice family physicians and group practice contracts for family physicians. My name is Sharon Shore. I'm the Senior Manager of Communications and Media Relations for Doctors of BC, and I will be moderating tonight. So you will be hearing from Mr. Paul Straszak, our Chief Negotiator. Paul and his team have been consulting with government while these contracts were in development. You will also be hearing from Mr. Mark Armitage. He is the Assistant Deputy Minister of Health, and he led the development of these contracts. Also tonight, we have Dr. Trina Larson-Souls. She is Chair of the Statutory Negotiating Committee, and she was involved with the contract discussions as well. Please note that your video and audio are turned off. So tonight, our format will be as follows. Paul will spend a few minutes talking about the contracts overall, and then he will hand it over to Mark, who will talk for about 40 minutes or so, providing greater detail. After the presentations, we will open it up for questions and answers. At the bottom of your screen, if you hover your cursor, you should see a couple of icons, Q&A and chat. So if you're having any technical issues or other concerns, chat is where you will let us know. You will use Q&A to type in any questions you may have, but please don't use chat for questions. Feel free to type in questions as Paul and Mark are speaking, but I will relay them after the presentations are complete in the order received. And questions will be posed to Mark. Paul and Trina will add anything they think relevant. Questions can be asked anonymously if you would prefer. That option is in the Q&A box. If you don't have a question, feel free to click on the Q&A icon to see the questions that are being asked. As a note, this webinar is being recorded and will be made available to anyone who would like to view it later on. I think it should be pretty straightforward. If you have any questions about the process before we start, just please type it in the Q&A. Okay, so seeing no additional questions, let's get started. Paul, the floor is yours.
Great, thanks very much, Sharon, for the introduction. What I'd like to do is to start by providing you with a background on Doctors of BC's collaboration with government on these new contracts, and then Mark will take you through the contract detail. So the consultation process that led to these contracts was established in the last Physician Master Agreement negotiations. Under the PMA, the Ministry or health authorities have the right to create new compensation contracts unilaterally as long as they don't conflict with the PMA. These contracts are then negotiated locally, and physicians have the right to accept them or reject them or negotiate changes. There's no explicit role for the Doctors of BC. But when we entered the last round of negotiations, the parties identified a joint interest. We both wanted to develop new compensation models that would address the changing interests of physicians and would support the primary care network principles that reflect the ministry's objectives in primary care reform. As a result, we agreed to a new process for consultation where the ministry plans to introduce any new payment model for broad application. It's in the Memorandum of Understanding on Compensation Model Consultation. To be clear, this does not detract from the government's right to unilaterally determine provisions of any contract to offer to physicians, but it requires the ministry to seek Doctors of BC input on the design of the new contracts. The ministry triggered this process to develop a new payment model for physicians with an established primary care practice. As per our agreement, Doctors of BC called out to members and selected a panel of physicians with expertise on primary care contracts to engage with Mark and his team. Trina is the chair of that committee, and she was joined in the consultation by 4 other family physicians from across BC and senior staff from Doctors of BC as well. As the consultations progressed on the group contract, we also identified the need to update the individual contract for new to practice physicians, as we saw the need for both contracts to work together. So Mark will be presenting on both of those new contracts today. But before Mark gets into the details, I want to share with you the high-level objective of the physicians on the Committee for the New Compensation Model. We support the Doctors of BC policy that there should be a plurality of payment mechanisms available to physicians so that they're able to select a payment model that matches their practice style. To be clear, in the context of the consultation process, as distinct from what we might seek in negotiations, our objective was not to seek the highest level of compensation to physicians in primary care practice. which is not to say that we didn't push on the money side. We certainly did that. But our objective was to create a payment model that presents a reasonable payment alternative for some physicians, and particularly those who provide longitudinal primary care aligned with the best practices that we're developing at the GPSC. We concluded the consultation process with the ministry in late August, and we feel that the contracts meet the objectives of our members on the committee. We think the new models will provide a reasonable compensation alternative to physicians in the primary care setting. The analysis is clear. It will likely not be attractive to some family physicians, especially those who've been able to optimize their practice in a fee-for-service setting, but we expect it will be attractive to a significant group of family doctors. As it pays by the hour and not specific services identified by the Medical Services Commission, it provides physicians with greater clinical freedom to provide the best primary care services to their patients, similar to what happens in a population-based funded practice. And the new model includes a first-year payment guarantee to provide physicians with an economic safety net as they become accustomed to the new payment mechanism and the new style of practice. So with those introductory comments, I'll pass the presentation over to Mark to outline the contract details.
Great, thanks, Paul. And can I just confirm, Sharon, that you can hear me okay?
Sorry. Yes, I can hear you okay. However, you could speak a little louder perhaps.
Okay, I'll do my best. And I just want to make sure also that everyone can see the PowerPoint deck, because I thought I heard you say at the beginning it may not be available to some. So it is being presented?
Yes, I can see it.
Okay, great, thanks. Sorry about that, folks. I just wanted to make sure everything was working right before we started. So first of all, I just want to say thank you to all of you. When I look at the participants list, it looks like we're up to about 509 participants tonight. That's absolutely amazing. So first, thank you for taking time at what I know is the end of probably a long day for many of you. And also just on behalf of my colleague, Ted Patterson, who's the ADM of Primary Care at the Ministry of Health, and our Deputy Minister, Dr. Stephen Brown, I just wanted to say thank you for the work that you've been doing in primary care, particularly in these particularly challenging times through the pandemic. We certainly recognize the strain it's had on many of you and on patients, and just wanted to acknowledge the great work you've been doing and to say thank you for that. I'd also like to just say thank you to Paul and the team for Doctors at BC. As Paul referenced, we've been in a consultation process for a number of months. While I think we would agree that it took longer than what was anticipated because of wanting to make sure we did the best job we could, and at a certain point in time getting knocked off course a little bit because of the pandemic. I think overall we had a very collaborative and open process, and I just want to say thank you to Paul and the team for such a great consultation process. I'd also just like to introduce three of my staff that are with us this evening. I have my Executive Director of Compensation Policy and Programs, Marie T, and two of her directors, Jeff Homer and Nia West. And amongst the four of us, plus with support from HEABC, we made up the team that worked with Paul on what we're going to review tonight. So I'm just going to kind of jump into this. I'm going to try to go through this as quickly as possible because I really think the richness of the dialogue is in the questions at the end. So please, as Sharon said, please make note of your questions. In the event that we don't get to all of the questions tonight, the ministry is committed to provide written responses as well to the questions, both for your own benefit and also so that you can share with your colleagues. So just to kind of jump straight into it, essentially what we've negotiated for existing GPs is a group contract for physicians, The contract is between the physician group and the health authority, but just to be very clear on it, the health authority's role is simply to administer the contract in helping to set it up. They don't control any of the terms and conditions of the contract. Those are specifically the property of the ministry. In the consultation process, we made a commitment to the doctors of BC that should there be any issues that we've identified as we roll these out, that they will come back through the same consultation process for review. I guess the next thing I just point out is that this is a group contract, and we agreed through the process that the minimum size of the group is 3. So these contracts are not available to solo practitioners, and that's in part to support the policy direction that's shared between the ministry and Doctors of BC and GPSC around patient medical home and primary care networks. I think one thing it's really important to note though is that those 3 physicians do not actually have to be co-located together within the same practice. They could be perhaps working out of the same building, or working in a cluster of buildings, or even further apart. The only sort of proviso we put on who can go into a group is that they need to stay within their primary care network boundaries. And I know that for many, they may not be in the active stage around primary care networks. So in those circumstances, we would work with you around assessing whether the group makes sense or not. I think the other thing which I would just like to point out is that we did discuss how and where and when we would make these contracts available. And we agreed with Paul and the team that they would not be made available only to primary care communities, that they would be made available across the province. And that was under the principle of giving people equitable opportunity and then not being linked to a strategic initiative. As we've covered off, the intent behind these contracts and how they're structured really is to promote and align with patient medical home and primary care networks. The initial term of the contract is 3 years, and it has a 6-month notice termination. So if somebody enters into it, or a group enters into it, and they decide that they, for whatever reason, it is not a good fit for them as a group, then they do have the option to give notice and terminate it. And just with respect to the term, even though it's 3 years, I don't want to leave any misconceptions. This is a ongoing payment option that the ministry is making available. The 3-year term is simply to keep the contract template in accordance with government's rules around contracting. But there is no plan to in any way to have this as a pilot. This is seen more as a now a foundational part of our compensation framework for the province, and will be made available going forward. One of the key things in this contract is at the end of the day, within the payment that's provided in the contract, physicians continue to be responsible for their own overhead and management of the practice. And the reason for that is essentially presently a number of many physicians that run individual clinics or are in a group, they make a series of their own independent business decisions about who they're going to hire, how much office space they're going to have, what type of equipment they're going to have. And rather than the ministry wading into that in any way, we thought that it was better to leave that to physicians to manage and not to disrupt any sort of existing agreements and to reflect the need for overhead as part of the compensation within the overall compensation package that's available through the contract. So just to provide a few more details, we had a lot of discussion about how to quantify physician time. When you look at how physicians practice across the province, it really varies. I think I would say over a number of years, there's been shared interest in trying to move to a more common definition of what full-time physician's time looks like. And we landed on what is a pretty regular time frame in other AP contracts we have, which is the minimum being 1680 hours and a maximum being 2100 hours. Now, just to be clear, if you do the 1680 hours, you're entitled to the full payment of 1 FTE. So even though there may be a bigger range, and we'll get into that a little bit more, the financial compensation is determined based on that 1680 number. The other thing that we've heard and certainly experienced is that many physicians are interested in practicing in different settings, or they may be interested in working less than full time. So we've allowed in the contract for the opportunity for physicians to practice at a 0.5. Obviously, the payment would be prorated based on whatever percentage of the FTE was being worked. The reason we chose 0.5 was because in discussion with Dr. Brenda Heppard and other members of GPSC and also with Paul and his team, we believe that to meet the deliverables and objectives within patient medical home and continuity of care for patients, that 0.5 was a reasonable spot to draw a line. Anything below that, and there was concern that it may disrupt that longitudinal relationship. And then with respect to the funding, it's essentially made up of 3 elements, and it has a range of $269,664 up to the $329,664. And that's made, as I say, up of 3 pieces. The first part is a base rate, which is essentially paying for time, which is at the 1680 hours, which is the 269,000. There's an opportunity to add to that 269,000 additional $20,000 for participation in quality improvement activities, and I'll say more about that later. And there is an escalator within the contract that takes into account both the volume, so the physician's panel size, and the acuity of that panel up to an additional $40,000. And what the contract essentially does is it sets out the following services, which is comprehensive primary care services in community clinics. And I think that's a really key point. This is about in-clinic services. We'll talk more later about services that may be provided in long-term care or in hospital, but this is essentially for time in clinics. It's intended to cover off providing access and attachment, quality improvement, clinical administrative services. So this is inclusive of, you can use the time for covering off your charting and recording requirements. And there is an option as also to take into account clinical teaching services as well for physicians who are interested in that type of work. And then with respect to the actual services, they're consistent with the basket of services that are identified within the patient medical home policy directive for in-clinic care. So you see them listed there, and I'm not going to go into them just because I'm sure they're very familiar to folks. Now, some of the key sort of elements of the contract, as I mentioned, is around access and attachment. And what we're looking for within this contract is for physicians to have the conversation with their patients, both their existing patients and any new patients that they bring on, around them being attached or registered to the clinic. You will most likely have a most responsible physician, but the notion is really that the patient is attached to the clinic rather than to an individual physician. That after that conversation has occurred, the physician is to submit an attachment code indicating they've had that conversation. And there will be a verification process for patients as well. And the ministry is in a process of developing what that'll be. But essentially, we will be contacting patients and confirming with them that they understand that they are registered to a particular clinic. Another key aspect of this is to really understand access. So we're within the contract, there is an expectation that you track and report on the third available appointment. I just want to stress on that one in particular, there is no performance, well, I shouldn't say there's no financial penalty with respect to directly about this particular requirement. It's not like if you are, if your third available appointment is 3 or 4 days out, it's not like there's going to be some type of penalty associated with it. It's more so that we can get a lens and understanding around what access looks like, and that we can work from a quality improvement perspective about how we can support physicians and clinics, and also work across the province to improve access. So I just wanted to be clear that it's not there's no penalty around it. It's just a part of the data that we're looking to collect. I think the other thing that we focused on here was rather than making it very prescriptive about how many hours an individual physician works in a day or within a week, or how many patients they saw in an hour. What we focused on was really at the local level, negotiating the operating hours and the daily staffing levels that the clinic would be open. So that is essentially, you bring forward, if you're interested in this contract with a group, what hours you plan to work as a collective and be open and available. But how you provide coverage during that time is really within the group to decide. With regard to extended hours, I'm sure folks will be aware that one of the desires and directions is that coordination for extended hours is done within the primary care network. So it may be that you're doing a portion of that within your regular clinic hours. And it's also that over time, the ideal is that as a primary care network, that you have that mechanism for extended hour coordination and coverage. As I mentioned, this is about individuals being, or patients being registered to the clinic. And so there is an expectation within the contract that you provide cross coverage. And if you do provide cross coverage, you can account for your time in doing that, but you cannot bill additionally under fee for service for it. So it's different than having a circumstance where it's a fee for service clinic, everyone's on that model. If the one physician's away and another physician is covering, they simply bill for whatever activities they provide. In this case, it's a matter of recording time and the practice agreement and how you manage that within the group. And as far as how time is distributed across the year, we agreed that the maximum number of hours that a physician could do in any 2-week period was 90 hours. And that was for a series of reasons. One is it helps to ensure that there's coverage, to a reasonable level by that physician across the year if they're in a one full-time FTE position. If you are in a 0.5 position, obviously that number of hours per 2-week period would be prorated to 45. And so rather than, again, like making sort of prescriptive rules, we really left it to a group decision on how they provide cross coverage and how they work. But we did put some guardrails around it, in part to ensure that there's the physician has a presence throughout, the majority of the year, and also to really kind of pick up on some of the findings or comments that we heard, and we've heard through the visioning process around creating compensation and working environments that are conducive to work-life balance. So, while it doesn't drive obviously what we're doing here, it was a factor that we considered. And then the last thing I'll just say on this slide is that we are at the end of each year, we do a bit of a review of the panel at the ministry, and that's really just to understand if the panel stayed stable, gone up, gone down, and we use that information, as we'll get to in a minute, to determine or help guide us around compensation levels in the future years of the contract. So on the issue of quality improvement, I think the key things I want to highlight here is that we've accounted for within the hours of the contract that physicians can bill for 1 hour per week for quality improvement activities. So ostensibly within the 1680 hours, you can, if you chose, to utilize up to 52 hours of it over the year for QI activities. With respect to what quality improvement services are done, there is a requirement for 2 mandatory ones. One is participation in the patient experience tool, and that's for both GPSC and the ministry to get an understanding of how patients are experiencing this tool. Again, there's no performance penalty based on the information that's collected there. It's all being done under the auspice of quality improvement and learning, both for how we develop these contracts and for physicians on how they provide services. There's also a mandatory requirement for panel management. During year 1, you have to complete that process if you haven't done it already, and you have to have it as an ongoing process. And then if you are greater than a 0.75 FTE, you're required to choose from a suite of QI activity options to participate in. And if you are less than a 0.75, you have to choose one. And those other items, I don't have them with me, but they've been developed in collaboration with GPSC, and they are consistent with those activities that support patient medical home. Now, besides being able to do this contract allowing for in-practice, in-clinic services, there are also a number of areas where you can continue to bill fee-for-service if you are interested in doing that. You can see the list there. You continue to be able to bill for third parties such as WorkSafe or ICBC, or services to non-BC residents, and for non-insured services. And you can also bill for specialized services to patients who are referred by practitioners outside of the clinic. The example of this is you may live in a community where a physician has a subspecialty, let's say in diabetes, and within your network, you may refer a patient from one clinic to that physician in her or his clinic. And in that case, that physician who's receiving the referral and providing that specialized service to somebody who's not attached to their clinic is able to bill fee-for-service for that time. In addition to that, for services provided in a hospital or other facilities, you continue to bill fee for service for those. And we've agreed that physicians will be able to continue to bill for the networking fees for inpatient, maternity, and residential care, ostensibly because those are about networking and not direct in-clinic care. The only sort of caveat on all of that, obviously, is you can't double bill. So you can't account for your time and also bill those for fee for service. So there is a requirement that you account for the time that's being charged against the hours in the contract, and also required to estimate the amount of time that's spent doing fee for service work in any given day. Now, with respect to some of the other elements of the contract, the payment mechanism in the contract is through the health authority. They will provide a payment to the clinic. For physicians who are interested in this option, you will know up front at the beginning of the year what the clinic's annual income would be, and that income would be broken out into regular payments to the clinic. And then the clinic then determines within its own internal agreement how those funds are dispersed. So just to be a bit more specific about it, my team at the ministry would do those calculations, give you a picture of what the annualized value at a clinic level or a group level would be. You then have a choice on whether to enter into that contract arrangement. If you choose to do that, you then decide within the group how you disperse the funds. What we're looking for in return for that is obviously clarity on the hours and days that the clinic is open, and the other criteria that I've outlined about how and when services are provided. And we recognize that this is a substantive new model and a change, and so we wanted to create a mechanism for an income guarantee for physicians. So what we've done is basically what we'll do for groups that express interest is that we will do some analysis of those individual physicians within the group's 2019 fee-for-service billings, and we will obviously show that to the physician, and then based on what those numbers are, we will provide an income guarantee. If those earnings are below 269,000, then the income guarantee will be set at the 269,000 per FTE plus the 20,000 for QI. If they are above the 269, then they get the greater amount to a maximum of the 329. So there is a range in there, and there's a process that we would go through to make sure physicians understood what they billed and what they would receive as compensation if they chose this model. The reason for the 2019 year, as opposed to a 2019-20 or actual billings to date this year, is really because of the pandemic. We were concerned that basing it on this year might skew the numbers in some way. And so we've purposely chosen the 2019 calendar year because we thought it would be the most stable payment time period. Now, at the end of that first year, there is a reconciliation process that occurs around the income guarantee. And it's possible that if the physician has worked in a way that they're, when we've applied the escalator for volume and acuity, that that they should have earned more than what the income guarantee is, then we will adjust it up. And it's the same the other way. If the hours aren't put in or the QI activities are not completed, then there's an adjustment down. And then sort of going forward for the second and any subsequent years of the contract, the payment is really calculated, as I said, based on that base payment for hours worked of 1680, the panel size and complexity, and the participation in quality improvement activities. And as I mentioned, in future years, there continues to be an annual reconciliation process to assess and adjust the contract values as required. Now, with respect to the contract sort of and some of the elements of it, the calculations for how to determine the payment for volume and acuity is based on an expectation that physicians are carrying a panel of 1,250 patients with an average complexity. At the end here, I'll probably get Jeff to provide more context around this, because this is really his area of expertise more so than mine. But it is based on that as the expectation and average complexity. There is an adjuster within the methodology that adjusts the payment based on individual patients' complexity using the Johns Hopkins ACG system to adjust the payment. Panel size expectation is adjusted upwards and downwards to the extent by which physicians' actual panels and complexities differ from the average complexity. So what it really means is that we've created a reference point at a provincial level, and then depending on the individual practice and the profile of the patients they see, the payment for that $40,000 is adjusted depending on that. And as I mentioned, we did earlier on, there is a process where, for whatever reason, that services are provided to a large number of unattached BC residents, or clinical teaching services are being provided. There can be some negotiations and adjustments around panel size to account for that. And then around the issue around physician accountability within the contract, what we're requiring is physicians to report quarterly on their hours of service for each day worked. They have to do patient encounter reporting. Just like to point out that this is not shadow billing. It's a simplified process. The reason that we have this simplified encounter reporting process is really for 3 reasons. One is so we obviously have a record of what services are being provided. Second, it's so that if there's ever any questions about it, we're able to reference back and understand what was provided. And the third is the data is fed into the BC Health System Matrix, which allows us to understand at a population level what's occurring around the province for the residents of BC. Just as an aside, and just because people often are interested in it, that data is highly controlled. It is not easily accessed. You have to have a high level of clearance to access it. Any type of time we make it available to the majority of people within the ministry, it's always anonymized, so you can't tell who anybody is. So just to make it clear that even though that data comes in, and it already comes in, so this isn't a change, this is exactly what we're doing presently, but that data really is highly controlled for obvious reasons. There is a requirement also within Teleplan to report daily start and stop times, and to estimate time spent providing services under the contract. And what I mean by that is, this is about providing services within the basket of services in clinic. If you provide services outside of the clinic, as the ones I listed, then you can't account for your time within that. There is a provision within contract for the Medical Services Commission to audit. There is no plan, just to be clear, to do proactive audits on these contracts. They will be managed and governed the same as all physician compensation models in the province. And I would just like to stress that because this is a new process, we're very much entering into it with a quality improvement lens, as we have with other alternate compensation models, such as population-based funding. We're all interested in having success and learning, and so that'll be the lens that will be brought into any type of review that might occur. I'd also like to point out that within the contract that the health authority may initiate an audit, but they do not have in any way any access to individual physicians' EMRs. The only people that would have access to that information would be consistent with how the commission has access to it now if they're doing an audit using the fee-for-service system. And so just to provide a bit more detail, to operationalize these contracts, it does require that there is a group practice agreement that's established between the 3 or more physicians. Within that, we believe they need to cover off areas like distribution of payments, allocation of clinic costs, and other clinic operations and management issues. And the Doctors of BC is in a position to provide a framework of those issues for consideration. At the end of the day, these are contracts, and so we'd like to point out that things like the legal rights in this under this contract and any sort of Canada revenue issues all have to be looked at by individual physicians. We're not in a position to be providing legal advice or accounting advice. Physicians have to make their own informed decisions based on the advice they get. So that's the established contracts. Just quickly, I'm going to run over the new to practice contracts and then wrap up in the next sort of 5 or 6 minutes. So just as context, likely some, if not many of you on the line will recall that back in 2018, we released, after consulting with Doctors of BC, the 200 GP, new to practice GP contracts. You know, I think that was a first foray into this space, and certainly there was a lot of learnings from that. One of the key issues that was identified was around the issue of rate. There was, you know, concerns raised by BC family doctors and by the profession around the rate. And so we've spent the time really reflecting on that because, you know, at the end of the day, we're not interested in creating things that don't work. We're interested in creating things that are going to resonate for the profession. So we committed through this process that not only were we going to look at a contract option for existing physicians, but we needed to also do a bit of a review and reset on the new to practice contracts. And so through this process that we did with Paul and the team, we did review those contracts as well. These contracts have a few things which are a little bit different. There's many similarities, but just to highlight some of the differences, these new to practice contracts can be with individual physicians and the health authority. Again, the contract terms are sort of governed and held by the ministry, and any changes to those will go through another consultation process with Paul and his team. For physicians who are interested in these contracts, these new to practice contracts, and new to practice really is probably a bit of a misnomer. It should be for physicians who don't have an existing panel. So if you've been doing locum work or working in other settings, you can still move on to this contract. What you can't do is if you are providing, have an existing panel, switch over to this payment model. So the new to practice physician must join a group as part of this process. but that group could be a fee-for-service group or it could be an AP group. So there's choice in there. And that group could be actually a group of new to practice physicians who are interested in coming together. For example, maybe there's a cohort of recent grads who want to come together and start working. We would don't have an existing panel. We would be willing to look at creating a contract with them to provide service. Again, this is going to be made available throughout the province, and they align with the principles of patient medical home and primary care networks. What's different here is that we've gone from the original contract of being 3 years down to a 2-year term. And I'll explain that more in a bit. But like the existing physician contracts, the new to practice physicians are responsible for within the payment covering off overhead. Within this contract, new to practice physicians are paid the same for their time. It's at that 1680. It's the same figure of $269,664. There is no automatic payment at the front end for doing quality improvement work, but assuming the new to practice physician does that, they will get an end of year 1 bonus for $10,000 for participating in the QI and meeting an attachment target of 800 in that first year. In year 2, that QI amount can be increased to $20,000, same as the criteria as in the inpatient contract. And in this particular contract, there is because they don't have access to the volume and acuity adjustment process, we agreed on a 2% lift for the fiscal year 21-22. And the reason it's only for 1 year is that by the time we get into fiscal year 22-23, we will be back at the physician master agreement negotiation table. And we've agreed that that's the better venue to talk about how compensation under these contracts should be adjusted in the future. So what we're doing is building an interim approach on how to manage it. Same as in the existing GP contracts, this does also allow, under the same sort of rules and provisos, limited fee-for-service billing. So I'm not going to review that again, just to say that they're congruent to that end. There is a requirement, there's a practice agreement, similar to the existing contracts, really to lay out the new to practice physician schedule, contribution to overhead, and a number of other elements. And again, we believe that to make this successful, that it's necessary for new to practice physicians to work with whatever clinic they're joining, to have some form of a group governance agreement and or associates agreement. Again, this is very consistent with the existing GP contracts. So it's a full-time equivalent is based on 1680 hours. The minimum is the 0.5 that we're willing to go into, but that's consistent with what we've said before. The maximum number of hours is those 90 hours that I mentioned. And the attachment targets, you can see there for year 1 is 800. And this for year 2, it's 1250. And then again, it's consistent with the existing GP contract around services, around what's within the, can be accounted for time within the contract. And we did build into this contract a little bit different opportunity around transitioning. So essentially, at the end of the 2-year term, the physician will need to make some choices about what they do. These are short-term contracts in the sense that they're a 2-year term. The option is to transition to fee-for-service or to join an existing group AP contract. So there's choices there. If during the 2-year period, though, the new to practice physician decides actually they would like to get out of the contract with their panel and join a group who's operating under an existing GP-AP contract, they can do that with 60 days notice. And once they make that transition, then they are afforded the ability to access the escalator for volume and acuity. So we think the advantage to this contract is that it obviously provides, again, an income guarantee when people are starting out practicing. And then when she or he feels ready, they're able to make a decision on what long-term compensation approach they want to utilize. The accountability processes, again, are the same as those that are under the in-practice group contract. The auditing process is the same as well. And then just on the issue of implementation, just to be really clear, these contract options have been reviewed by the Ministry Executive and Minister Dix before the election was called, and was basically approved to release. The Doctors of BC Board and the Family Doctors of BC also had the opportunity to be briefed, as did GPSC. We've done sort of all the required due diligence on the terms and conditions. And so we're poised to be able to roll these out. I'm sure there's going to be lots of questions over the coming weeks, and I can see that we're up to 196 questions now that have been logged, so we're going to take some time to respond to them. But essentially, as physicians are interested in knowing more about it and finding out as a group, what does it mean for my clinic, we will set up a process whereby physicians can express interest in the Ministry of Health. And the ministry will provide some analysis back on what the compensation will be. So that's the end of the presentation. I've gone longer than I had hoped, so apologies for that, but we've still got a good 36 minutes to get through some questions. So I'll turn it back to Sharon at this point.
Great, thanks so very much, Mark. As Mark indicated, we do have a large number of questions. We have more than 200 now, so we will not get to all of them. But we can email and answer back to the questions we didn't get to, unless of course it was asked anonymously. Some are duplicate topics, so if I ask a question that doesn't completely answer your similar question, or if you think if you think of a question after this webinar is over, please email it to negotiations@doctorsofbc.ca, and you will receive an answer back. As well, please know that if your question is more complex, the regional advisor and advocate in your area may well reach out to you. We have an RAA in each health authority, and their job is to support physicians in their communities and are the first point of contact to assist you in seeking services and support from Doctors of BC. So let us get started with the questions. Please let us know about the overhead with the clinic when choosing alternate plans in urban areas.
So I'll give a go at this. I'm not, just to, it might need some help if there's a follow-up question to this one, but essentially, as I said, in the discussions we had with Paul and the team, we made the determination that rather than being prescriptive on a payment for overhead or what could be billed for or not billed for within the contract for overhead, that we would be silent on it, that we would create an overall funding envelope based on those 3 elements that I've identified, that the physicians then within the group would make a determination on how they, what they took out for income, what they paid against overhead. So it really it sort of remains that physician autonomy around making decisions on how much and where and how they they disperse the funds that are within the contract. And then within the new to practice contract, it's ostensibly the same approach, but that individual new to practice physician would have the conversation with the clinic that she or he was wanting to join to understand what that might look like before they enter into it. Paul, is there anything else you'd like to add to that, or is that a reasonable summary?
The only point I'd like to make is that when physicians choose to accept this contract, they have to understand that they're going to have to pay their overhead out of the money that flows in.
Okay, thank you. What's in a name? Initiative. Does this mean it's a test process and will be analyzed and possibly withdrawn?
So it, perhaps initiative is the wrong word to use. It is a new compensation approach, and we've committed to Paul and the team to do quality and improvement on it as we learn over the years. We did our best to design this, but we will obviously uncover things as we go along over the next coming years. There is no plan whatsoever to withdraw it. And if you actually look at the history within the province, we may have stopped offering a particular compensation model, but we've never withdrawn that compensation model from a physician group that went into it. So it's only the only time that we've stopped providing it is when a group has said to us they don't want to continue anymore. So we're going into it with that same approach, that this is now a formal part of our suite of compensation models that we will maintain in the years ahead.
Great, thank you. Is it possible to do 0.5 FTE in one PCN region and 0.5 FTE in another PCN region? For example, can I work 0.5 in Vancouver and 0.5 in Surrey?
I think conceivably, yes. There's nothing in this contract that prevents you from doing that.
Thank you. When do you anticipate the new contracts to become available? What are the next steps for interested parties at this date?
So there's a few sort of pragmatic things that we have to do. We want to make sure that we socialize the contracts, we respond to questions so that people have information, the best information we can provide. We're targeting the latter part of October to make the opportunity for expressions of interest to be made. It might go into early November, but we're looking to do it this calendar year. We're not waiting later into the new calendar year at all.
Who were these expert physicians consulted regarding the contracts?
Turn that one over to Paul, I would suggest.
Yeah, so what we went to, we filled the committee in the same fashion that Doctors of BC staffs its other committees. So we went out to our physicians and said, who's interested? We had a significant group of physicians identify, something in the neighborhood of 50 or so physicians identified that they'd be interested in participating in a committee of this sort. We particularly raised the issue of discussing a contract of this nature, a primary care contract. So we had lots of primary care physicians. On recommendation from our chair of the negotiating committee, Trina, and review by the board selected 5. Trina is chair, Adam Thompson from Comox, Goldis Mitra from Surrey, Bruce Rebner from Pender Island, and Jiwei Lee from Vancouver. Those were the 5 members, the physician members of the committee, and they are supplemented by support from myself, Brenda Hefford, Tom McPherson, Jim Aikman from Doctors of BC. So we had a fairly extensive committee with a lot of experience on it.
If I could just add, I wouldn't call us a group of experts, but what we had was a diversity of experience that spanned a lot of practice models across the province, and that's what we were aiming for in these discussions.
Great, thank you. A number of questions, a number of people are asking about whether or not there's a limited number of these contracts being offered.
The short answer is no. There is no cap on the number that are being offered. The only issue that is an unknown to us is what the interest and uptake is going to be. And so we may have to sequence how many we can do in any given month, but there is no upper limit on or cap to the number that could be offered. So if you are interested but choose not to do it right now, but come back in 6 months, the opportunity is still going to be there for you.
Thank you. Another question that a number of doctors are asking is, what number of hours needs to be devoted to charting?
So what we've tried to do in this is not be prescriptive around activities such as that. We see that as one of the elements of providing care that's required. You know, physicians have choice on how they utilize their time. So essentially what this does is it allows physicians to perhaps see people once for a longer period of time, deal with multiple, you know, perhaps issues that that person may have, and then chart once at the end of that. So there is no, you know, parameter around how much time you apply for charting versus direct patient care. What this does is give clinical autonomy about how you utilize your time.
Yeah, let me jump in on that a little bit more. The bottom line is all of your hours on charting can be counted. But imagine if you spent all of your hours on charting, then you wouldn't be able to maintain an attached population of the volume and complexity that would drive the payment. And so that would be the trade-off. But the notion is that the physician can make his or her own best decision as to how they apply the hours.
Great, thank you. Can we continue to see consults and bill fee-for-service to MSP for those patients while under this contract?
So maybe I'll defer to Marie on this one. She's probably in the best position to answer that question.
No. So what you're being paid for is for the longitudinal care of patients. So if it's for consults for your patient population for that full service care, no. However, if it is for a specialized service, then in that case, it is outside the scope of this contract. So it depends on what consult one service that you're providing.
Yeah, just to add to that, you know, if a physician within a clinic has a specialized practice, you can't refer patients across and within the clinic and bill the fee-for-service, but if it's a referral from outside of the clinic to that individual physician, then yes, the physician is able to bill the fee-for-service code for that particular service.
Great, thank you. Can there be 3.5 FTE physicians working in the clinic?
Yes, the minimum number is 3. There is no maximum number. You know, we believe that the sort of the ideal number, you know, is probably less than 10, but that's just a bit of an estimate at this point. We didn't actually land on a maximum number, and if it's 3 or 3.5, that's fine.
Thank you. Are there provisions to use telehealth for healthcare delivery incorporated into working hours?
So yes, this does not require those in-clinic services to be provided actually in clinic. This does allow for virtual or telehealth services to be provided. Having said that, obviously issues around appropriateness of clinical care, any rules that the college might have about how things are done have to be followed. But we're not within the contract prescribing one way or the other that you have to, you can't do virtual care or you have to do virtual care. There's physicians can choose how they provide that service, but it has to be obviously consistent with the presenting issue and how that's best addressed.
Great, thanks. For those already on the old 2019 individual new to practice contracts, what is the process for updating to the 2020 new FB contract? Or do those contracts have to be completely canceled and then re-signed?
So what we will do is we will work with physicians that are on those contracts. We'll give them choice. They can choose to stay on that contract if they want, to my earlier comment that we're not withdrawing something that we've already offered. If they, however, want to move over to this new contract, then we will work with them around that transition. And it'll be very straightforward. That contract will have to be canceled, but we will seamlessly introduce the new one, so there's no disruption in pay.
Great, thanks. Can you open up a new clinic as long as it's goal directed to PCN? Do you need to hire other allied health professionals in your newly established clinic, or can you refer them to local allied health?
Yes, you can open up a new clinic, but this contract is really designed for payment for physicians for their time. If a group decided that they wanted to bring in an allied health provider or a nurse into the clinic, that's their choice. There is no obligation to do it. And also they can continue to refer out to existing services within the community or the health authority if they choose to do that.
Great, thanks. How will this work for physicians that practice maternity care? Can we join as a part-time FTE salary and bill our office mat visits to MSP as well as our delivery fees to MSP?
So we did have a lot of conversation about this, and so I'll have my best crack at this, and then I'll ask Paul probably to speak to it. But in short, if you have a specialized practice within maternity care, and patients are coming to you for maternity care, your time for in-clinic care, as I understand it, Paul, and you can correct me if I'm wrong, but is billed against the contract, but anything that's done outside of the contract with respect to the delivery or services in the hospital are billed fee for service.
Yeah, I think it's important to understand that this is not a contract for us for a clinic that just does maternity work. This is a contract for full service family practice that will accommodate some physicians within that full service family practice that do maternity work referred from outside. So if you've got a maternity specialty, and let's say 2 days out of 5, you get referrals from other physicians, those will be seen in the clinic on fee for service. If you get referrals from physicians inside of the clinic for patients that are attached to the clinic, those are paid on contract hours. But any maternity time associated with hospital services is paid fee for service. But important to understand that this is not a contract for just a maternity practice. It's a contract for full service family practice that can accommodate some maternity specialists.
Great, thanks. So we have a series of questions regarding new doctors. I'm a newly graduated physician. I do not have my own panel, but the physician I will be working with is willing to split his panel as he has over 3,000 patients. Would I still need to sign the new physician contract, or would I be able to do the group practice contract given that I find 2 other physicians to participate with me?
So we'll probably need to take that one away and give it some thought. But on first blush, if it is as you've described and the existing physician has gone through the panel management process and confirmed that it is an active panel of 3,000 patients, then conceivably I think we would be open to it. But I just need to spend some time, so we'll need to follow up with a more specific answer on that one.
And can new graduates still in provisional licensing pending examination take the contracts?
Oh, so there's again another question that I don't know the answer to off the top of my head. Paul, I'm not sure if you've got any insight into that or not.
Oh, I don't. Maybe the other members of the panel can help. I think we'll have to give that some consideration before answering.
Okay. And why is the group contract for existing MDs, why is the group contract for existing MDs but individual is for new to practice MDs?
Really, that's to create the opportunity for new to practice physicians, depending on where they are in the province, or where they'd like to practice in the province, to be able to join and work in those parts within a range of different billing modalities. It's a way to help them get established as individuals. And so they may want to join, they may be interested actually in being on a fee-for-service payment model long-term. And so as an individual, they have that opportunity to practice, get comfortable with their patient panel, get comfortable with the fee schedule, and then transition over to it. Or they may choose that they're going to want to join a group that's under the AP contract. So it was really designed as a mechanism for the maximum flexibility to hopefully create a good opportunity for physicians who don't have a panel to want to join practices and to help with recruitment issues that clinics are dealing with.
Yeah, I think I would say that these are options for different groups of physicians. The group contract is really an option for existing groups of fee-for-service physicians that are providing maternity care. So they have the option to move over. The individual contract is really an option for a physician that's starting a practice. They can go do locum work, they can go do fee-for-service work, and now there's another option for them to join an existing practice under this new AP contract.
Paul, you mean primary care, not maternity care.
Yes.
Yes, I do. Thanks. I apologize for that.
Thank you. Who decided on the practice size? It does not seem realistic for a full-time GP who provides longitudinal care in hospital to a practice full of 95-year-old Cadillac driving, golf playing, kerchief shaking seniors to take on so many patients.
Well, as I mentioned, the index was developed based on the size of the panel at 1250 and an average acuity across the lifespan. So in the example that's given, I think what you would find is that it's not reasonable to have a panel of 1250 with the profile that you've described. It's more reasonable for that number to be much less. And so what the methodology allows for is actually a smaller panel that's higher acuity for the individual to still get the same level of an escalator within the contract. I'm not sure, Jeff, if there's more that you'd want to say about that, but that's my sort of basic lay description of it.
Yeah, I think that's fine. If you want me to speak in more detail, I'm happy to, but perhaps we should, like, broad strokes, that's exactly right. And maybe perhaps we can move on to the rest of the questions rather than getting bogged down.
I just want to dive in a little bit here just to give you a sense. The notion is that we compare the complexity of the patients on the local panel to the average complexity in British Columbia. And so the 90-year-old high complex patients, if your average panel is 10% more complex than the BC average, then the formula will drive you to see 10% less patients. And that's how we balance complexity with panel size expectations. 10% more complex, 15% more complex, you get 10% less or 15% less patients to see as a target.
Thank you. Do all physicians within the clinic setting need to sign the contract? For example, if some choose to continue only fee-for-service, will this impact the clinic contract?
So it is possible within a large existing clinic for a portion of the group that are working within that clinic to go onto this model and the rest to remain on fee-for-service. I think the main issue that we would have to delineate is that patients are assigned to that group, and they provide cross coverage within it. You can't move patients back and forth or individual services back and forth between the fee-for-service and the patients that are being seen under the group contract.
Thank you. Do all physicians in the group need to be on the same EMR?
No. I don't believe so. Paul, you're looking surprised.
Yeah, I am surprised. I think we discussed a practical requirement that the physicians in the group would have to be on the same EMR. Otherwise, we wouldn't be able to count the patients correctly. I believe that that's a practical limitation that we talked about.
Oh, yes, actually, you're right. I'm mistaken. There is no limitation on which EMRs a group would use, but Paul's right that within a group you have to be on the same EMR. So thanks for that clarification, Paul.
What is the practical consequence if your practice is unable to meet the attachment targets, 800, 1250 listed in the contract?
Well, essentially what happens in that reconciliation process is the escalator for volume and acuity is adjusted based on panel size and acuity. So if you didn't hit that 1250 target, but you had a higher acuity, as Paul outlined, there may be no financial change to what the value of the contract is. It's only if you're down on the number and have a very low acuity panel, for example, like a panel of, I don't want to be stereotypical, but let's say individuals in their early to mid 20s who are generally healthy and don't have any predominant chronic underlying conditions, then you may find that in that context, if you had a panel below 1250, that there would be an adjustment. But it's not as simple as your numbers lower, you get less. It's that ratio between the two factors.
And let me talk though, because there was a reference to 800, which refers to a new to practice physician joining another practice and not meeting an 800 target. One of the consequences of not meeting the 800 target in the first year of a new to practice contract is that physician wouldn't qualify for the $10,000 additional payment that goes to meeting the target and meeting the quality improvement initiatives. So for new to practice contract, it would cost you $10,000.
Thank you. If one of us in the group decides to end the contract, what happens to the other physicians in the group?
Paul, do you want to take that one?
Yeah. One of the requirements of qualifying for new contract is that the physicians develop an inter-physician group practice agreement. And you'll certainly see this when you take a look at the framework we've provided. But one of the terms of inter-physician group practice agreement would be how a physician leaves the group. So the group may decide that there may be a penalty for a physician that leads the group, or the group may decide that they're quite happy to take the patients on that physician leaves. But the short answer to the question is that would be determined by the terms of the inter-physician group practice agreement that the physicians joining this new contract would have to sign.
Great, thanks. So a question about hours. The 1680 hours that are needed for a full-time GP, would this encompass all patient-related matters, charting forms, et cetera? And how are hours worked tracked?
So it does include all of those aspects of providing care, and they're tracked by recording the hours a day within Teleplan that are worked.
Thank you. Does the whole clinic have to commit to this model, or can a few docs in the group choose to participate while the rest stay fee for service?
There is provision for a minimum of 3 to go into this type of a group contract, and others within a clinic to remain on fee for service. As I mentioned, we would just need to be clear about those patients under the group being served by those physicians, and that those that were outside of fee for service would manage their own panel or panels.
Yeah, I think a way to think about it is if a group of physicians wanted to be, maybe they're operating in the same office, but if a group of physicians wanted to peel away from another fee-for-service group, they'd have to consider themselves like an independent clinic, operate as an independent clinic. And to the extent that there is work outside, they'd have to contract out with that, with other physicians from this independent clinic with their own individual responsibility or their own group responsibilities.
Thanks. How will locum coverage work? Are we able to have locums cover practice for periods of time? Is there a maximum amount of time? Does this contribute to your yearly hours, and will they bill fee for service or get a percentage of the salary?
So there's a long-winded answer to this question, and there's a lot in that one. I don't know, Paul, do you want to have a go at this, or do you think we should just try to write this out and send it to people? Because it's quite, you know, it's reasonable when you see the whole, but it's hard to kind of explain the elements.
Yeah, I think the short form is if a locum comes in and bills fee for service, they can be paid fee for service, but they don't charge hours under the contract. However, a locum can come in and charge hours under the contract as well, in which case they wouldn't bill fee for service. So there are two options for locums, but it's important to understand that the contract imposes a responsibility on physicians to cover each other unless it's not reasonable to do so. So a locum would come in for a long absence, but then the locum could bill fee for service, not be part of the contract, or bill hours under the contract and not bill fee for service.
Great.
We'll write this out too.
I've heard rumors and seen on public media some of the agreement that the nurse practitioners have. Will the ministry share the contracts the NPs have gotten so that our negotiation can be assessed comparatively? I want to know that the ministry values the family physician as a specialist in primary care. The numbers I have seen show that the hourly wage works out to the same for NP and family physicians.
So this was an issue that was present when we released the new to practice GP contract, at the same time as we released the new NP contracts. And so there was a lot of comparison that occurred. Through this round, really I think what I would say is for both Paul's team and my team, we were mindful of that issue, and we were also mindful of other work settings that GPs can choose to work within, whether that be urgent primary care centers, hospitalists, other settings. So we've considered that. We believe that we have made sure that the value of this contract against the hours is reasonable remuneration for hours worked for a physician, and is much more closer consistent to what you would see for physicians that are working in a UPCC or a hospitalist type position. And then with respect to the NP contracts, I don't think that they are sealed. I mean, they were available at the time and people did that analysis. So I just don't see why we wouldn't be able to. They're also, you know, the template at the end of the day is a government document, which is FOIable. So I don't see why we couldn't provide it. What we probably wouldn't do is provide individuals contracts that they've signed, because those are, you know, products between the party and the individual. But if you want to see the contract template that is used, I don't see any issue why that couldn't be made available.
Thank you. Do other GP incentives such as CME payments still continue?
Paul?
So physicians that qualify or are paid under this contract have access to all of the benefits that are laid out in the PMA, including CMA, CME, CMPA, PDI, and those benefits as well. So they're part of the contract.
Thank you. How can we get information on the PCN catchments? Are we automatically grouped with those in our catchment, or do we need to find other physicians to group with?
Well, some of them already are known because they've gone through the planning process and are available. For those that haven't got those boundaries clarified, I'm happy to get that information from my colleague, Ted Patterson, who's the head of of the primary care division and the lead ministry person on PCN rollout. So I can get that from him and make them available through whatever mechanism is the best to get that information to people.
Thank you. Since overhead costs vary throughout the province, generally higher in urban areas, is there a differential applied to the location general cost of overhead?
No, there is not.
Do we get additional payment if we work over 1,680 hours?
So Paul, again, help me on this one if I get this wrong, but within that internal practice agreement, if there's a decision, let's say by one member of that group to work less than the number of hours or the FTE that they originally contracted for, and that time is then shared or assigned to another person within the group, then there is flexibility within the inter-clinic agreement for them to pay for additional hours above that 1680. But, and there's also the option, as I said, for billing for time above and beyond those 1680 hours for a physician who wants to work more than 1680 by doing additional services outside of the clinic. Somebody may choose to pick up some ER shifts, or they may choose to do some other form of work in the community. So there is that provision, but the rate is really set for one FTE based on those 1680 hours.
Thank you.
I just want to pop in here and be clear. So if we were talking about one physician, not considering the sharing of hours between a physician group, and that physician commits to 1,680 hours, but works 2,000 hours, there would not be an increased payment. The increases in payment would be associated with services not under the contract provided outside of the clinic or in the hospital.
Great, thank you. If it is a corporate-owned clinic with doctors who have signed onto the contract, who owns the patient data?
I don't know the answer to that, other than that data continues to be, as it's always been, the sort of material and product of the clinic. If there's a nuance there based on the business model, I'm not aware of what that actually would mean. There's nothing in this process that's different than fee-for-service that gives government greater control or authority over patient-level data.
Okay, thank you. If a potential physician's group's decision about whether to sign up depended on their patient's complexity weight, how does the group find out the complexity weight?
So Marie or Jeff, do you want to talk to that process?
Yeah, sorry, I was looking for the mute button. So at the outset of the contract, there's really no data to look at attachment and the panel in the same way as the panel is determined throughout the contract term. So when we start on, when we assess the clinic for the contract after the EOI process, again, we look at fee-for-service billing data to get a sense for the first year income guarantee. But generally, the best estimate of what a clinic can stand to earn on a per FTE basis is the mid-range of the contract, plus or minus 7%, which unfortunately is the low end of the contract or the top end of the contract. Just because attachment in the fee-for-service world, complexity in the fee-for-service world is measured a bit differently than it is on the contract. So it's really not accurate to project fee-for-service data into data and a contract payment when the methodologies just don't align. So the short answer is the best estimate we typically have for any one physician or a per FTE physician is that they will meet the middle of the contract range plus or minus around 7%. So 289,644 plus or minus a small amount.
Thank you. So we are coming towards the end of the 90 minutes. We can have time for one last question. Is the Q&I also prorated per percentage FTE?
Yes, it is. Yeah.
Okay. Thank you. So we have a total of about 348 questions. So obviously we're not going to get through to them all. Our
Hopefully
goal
there's some
is
duplicates in there.
there are some duplicates. Yes, no question. So the goal is to answer specifically where we can. And what we'll do is we're going to expand upon our Q&A that we have on our website. So that will be included, these questions will be included. So yeah, so presuming your question was not asked anonymously, you can receive a direct email answer back. And the regional advisors and advocates may reach out to you to help you answer your more complex questions. So I hope that you found this webinar helpful and informative. A reminder that the webinar has been recorded and will be available. It will be posted to our website in the next few days. And again, if you have any questions that you think of later, please email them to negotiations@doctorsofbc.ca. So thank you very much, everybody, for joining, and thank you, panelists, for providing us with your wisdom. Wishing you a very good rest of the evening.
Thanks, Sharon. And I just want to again say thank you for all of you taking time. You know, we're still at 400 plus people, so obviously we didn't bore the majority of you to death, so I'm glad about that. And just again, thank you very much for the service you provide to patients and to the province. And I hope you have a good evening. Good night for now.
Good night.